Currently, a significant number of clinical trials and research studies are being conducted to assess the effectiveness of metronomic chemotherapy in the treatment of lung cancer. The preliminary results from these studies are quite encouraging, indicating that metronomic chemotherapy might play a crucial role in controlling the progression of lung cancer, particularly in its advanced or metastatic stages. In addition to being used as a standalone therapy, metronomic chemotherapy is also being investigated in combination with other treatment modalities such as targeted therapy, immunotherapy, and radiation. This combined approach aims to enhance the overall efficacy of the treatment by simultaneously targeting various mechanisms involved in cancer development and spread. When it comes to selecting patients for metronomic chemotherapy, it's important to note that it may not be suitable for all individuals with lung cancer. The appropriateness of this therapy is determined based on a variety of factors, including the specific type and stage of lung cancer, the patient's history of previous treatments, their overall health status, and their personal treatment preferences.
We aim to provide valuable educational and informational content. However, this video does not offer medical advice, diagnosis, or treatment guidance. Our content is not a substitute for professional medical advice, diagnosis, or treatment. We strongly advise consulting a qualified healthcare professional for any medical queries or issues. The medical information in this video is provided as is. We do not make any claims, express or implied, about the completeness, accuracy, reliability, suitability, or availability of the video content. Relying on this information is entirely at your own risk. This video does not recommend or endorse any specific tests, physicians, procedures, opinions, or other information. Medical knowledge is constantly evolving, hence, the information in this video could become outdated, incomplete, or incorrect. We are not liable for any errors, omissions, losses, or damages incurred from viewing, using, or relying on this information. It's important to note that each patient's situation is unique, especially when discussing clinical data and research on metronomic low-dose chemotherapy in lung cancer. Treatment approaches and outcomes can significantly vary based on individual circumstances. By viewing this video, you acknowledge and agree that the creators, publishers, and affiliates of this video bear no liability for any direct, indirect, consequential, special, exemplary, or other damages that may arise from its usage. Thank you for watching. Remember, always consult a healthcare professional for any medical concerns.
Now, we turn our attention to an extensive, multi-center phase 2 study, expertly led by Dr. Camerini. This research, conducted across several centers in Europe, was designed as a prospective, randomized, open-label trial. Its primary focus was on patients who had not yet received any treatment for their condition, known as treatment-naive patients. These individuals were diagnosed with TNM stage 3B, or stage 4 non-small cell lung cancer. Let's begin with Arm A, termed as the metronomic low-dose regimen. Within this regimen, participants received oral vinorelbine at a consistent dose of 50 mg. This specific dosage was given 3 times each week. Moving on to Arm B, which represents the standard weekly schedule regimen. In this approach, patients were administered oral vinorelbine at a dosage ranging between 60 to 80 mg per square meter. This treatment was given once a week. A key finding was the median progression-free survival without grade 4 toxicity. For those receiving metronomic oral vinorelbine, it was 4.0 months, compared to 2.2 months in the standard treatment arm. This indicates a significant delay in disease progression with the metronomic regimen. The disease control rate without grade 4 toxicity was also notable. In the metronomic oral vinorelbine group, this rate was 45.8%, as opposed to 26.8% in the standard treatment group, suggesting a higher level of disease control with metronomic treatment. Progression-free survival was another important measure, with the metronomic group achieving 4.3 months, and the standard group 3.9 months. In terms of overall survival, both groups had a similar median of around 7 months. Additionally, the quality of life was comparable across both treatment arms. Regarding treatment-related severe adverse events, they were less frequent in the metronomic oral vinorelbine arm, with only 25.3% of patients experiencing these effects, compared to 54.4% in the standard arm. Specifically, severe neutropenia occurred in 10.8% of the metronomic group, versus 42% in the standard group, highlighting a significant reduction in serious side effects. In conclusion, metronomic oral vinorelbine significantly extended the median progression-free survival without severe toxicity, in patients with advanced non-small cell lung cancer, unfit for platinum-based combinations as a first-line treatment. With a notable reduction in toxicity, and comparable overall survival in both groups, metronomic oral vinorelbine emerges as a vital treatment option for this challenging patient population, offering an effective balance between efficacy and safety. Of note, the outcome of unfit lung cancer patients is still poor. Let's explore a phase 2 study that investigated the impact of metronomic low-dose chemotherapy, in combination with bevacizumab, on advanced non-squamous, non-small cell lung cancer. This innovative approach in cancer treatment is particularly relevant for patients with this challenging form of lung cancer. In this study, the treatment was structured into 4-week cycles. The regimen included paclitaxel, at a dose of 80 mg per square meter, administered on days 1, 8, and 15. This was paired with gemcitabine, administered at a dose ranging from 200 to 300 mg per square meter on the same days. Additionally, bevacizumab was given at 10 mg per square meter on days 1 and 15. Patients underwent this treatment cycle for a total of 6 cycles. When examining the effectiveness of this treatment, the results were quite promising. Among the patients, 24 achieved an objective response, which included 1 complete response, and 23 partial responses. Additionally, 6 patients experienced stable disease, indicating a halt in the progression of their cancer. An interesting aspect of this study is that 40% of the patients had an EGFR mutation. Such mutations are known to potentially influence the effectiveness of certain treatments. Despite this, the combination of metronomic low-dose chemotherapy with bevacizumab demonstrated a notable impact on the patient's disease, suggesting its potential effectiveness. Safety was a key focus as well, with both hematologic and non-hematologic toxicities being reported as very low. This is a significant consideration, as it suggests that the treatment extends the period of disease control while minimizing adverse effects, thus potentially improving the patient's quality of life. In conclusion, the findings from this phase 2 study underscore the potential advantages of using a metronomic low-dose chemotherapy regimen combined with bevacizumab in the treatment of advanced non-squamous non-small cell lung cancer. These results offer valuable insights and new possibilities for effective treatment strategies in this field of oncology, with a focus on both efficacy and safety. Let's discuss another common metronomic low-dose chemotherapy approach in the treatment of non-small cell lung cancer, the use of oral etoposide. This particular chemotherapy has been widely studied, and is administered in 2 different dosing strategies. One method involves a dose of 100 mg every other day, and the other is a metronomic low dose of 50 mg daily. The effectiveness of oral etoposide in treating NSCLC has shown encouraging results. The rate of partial response to this treatment ranges between 20 to 30%. Furthermore, the median duration of survival for patients on this regimen is around 9 months. These outcomes represent significant findings in the ongoing search for effective treatments. Nab-paclitaxel, also known as Abraxane, demonstrates superior tumor tissue penetration compared to paclitaxel formulated with chromophore. This suggests that the optimal dosage of Abraxane may be lower than the widely adopted dose recommended by NCCN. In order to assess the clinical effectiveness and safety of Abraxane, in patients with advanced non-small cell lung cancer, who had previously undergone treatment in Japan, a randomized phase 2 trial was conducted. During the trial, patients were randomly assigned to two groups, one receiving Abraxane at a dosage of 100 mg per square meter, and the other at 70 mg per square meter on a weekly basis. A total of 81 patients participated in the randomization process. The results indicated similar outcomes for both groups in terms of progression-free survival, which averaged 3.7 months for the 100 mg group and 3.7 months for the 70 mg group, as well as overall survival with 13.5 months for the 100 mg group and 16.1 months for the 70 mg group. Additionally, the overall response rate was comparable, with 20.5% in the 100 mg group and 23.1% in the 70 mg group. However, it's essential to note that the incidence of grade 3 or more severe adverse events was higher in the 100 mg group, which is 57.5%, compared to the 70 mg group, which is 41.5%. Furthermore, the proportion of severe side effects was lower in the 70 mg group, with 4.9%, compared to the 10.0% observed in the 100 mg group. In conclusion, both the standard dose of 100 mg, and the lower dose of 70 mg of Abraxane, exhibit efficacy in previously treated non-small cell lung cancer patients, with the latter demonstrating a more favorable safety profile. Therefore, considering the results of this trial, the use of nab-paclitaxel at a dosage of 70 mg per square meter weekly appears to be a reasonable and viable option for the treatment of non-small cell lung cancer patients in similar clinical scenarios.
As we close our discussion today, let's recognize the ongoing efforts and advancements being made in the battle against lung cancer through the innovative use of metronomic chemotherapy. As a myriad of clinical trials and research endeavors unfold, the early findings bring a wave of cautious optimism. The prospects of metronomic chemotherapy, particularly for those grappling with advanced or metastatic lung cancer, point towards a new frontier in oncological care. The potential of this therapy, administered in low, consistent doses, lies not only in its capacity as a singular treatment but also in its synergistic use alongside targeted therapy, immunotherapy, and radiation. Such multidisciplinary approaches are instrumental in attacking cancer from multiple angles, thereby improving the chances of treatment success. Patient selection for metronomic chemotherapy is a careful process, tailored to individual needs. Not every lung cancer patient will be an ideal candidate. The decision hinges on the specific cancer type and stage, prior treatment history, overall health, and treatment objectives. The suitability of metronomic chemotherapy is refined determination, aimed at optimizing outcomes for each unique patient. For those whose lives have been touched by lung cancer, whether you are navigating treatment options or simply seeking more information, the Omega Precision Oncology Clinic stands ready to assist you. We encourage you to reach out, armed with your questions and empowered by knowledge, as you continue your journey. There is a community and a team of experts who are eager to support you every step of the way. Please do not hesitate to contact us. Together, with hope and concerted action, we can move closer to a future where lung cancer is no longer an insurmountable adversary. Your proactive steps today could lead to transformative outcomes tomorrow.